our Spokane County Commissioner, Mary Cooney, who's currently on her way, but was allayed with another engagement. So bear with me. I'll be a poor substitute for the short term, but she should be joining us in the middle of this meeting. If you have not already, please go ahead and put your name, organization, and title into the chat. We'll collect our participants through the chat. That verifies that we have everyone on board. And for those that will be giving updates and presenting today, if you could also, when you initiate your update, just give us a little background of who you are and your position. That'll be helpful for the members that are joining here regularly to know who is leading. Any questions, thoughts, feelings, concerns that anyone wants to share before we get started?
Justin, only that I see our letterhead says that Justin Johnson is now the Director of Community Service Department. So congratulations.
Oh, thank you, David. Yes, that was going to be one of my announcements today too. So the commissioners saw fit to, and our CEO, Scott, saw fit to promote me to director. So I will be leading the Spokane County Community Services Department and the Spokane Regional BH ASL on behalf of Spokane County. So thank you, everyone. That occurred here in May, but we're in a process of notifying all of our external counterparts. But yes, thank you, David. And everyone else, I see there's some chats coming in. Thank you. All right. Making sure we get everyone home on time on a Friday evening. Let's start off with our first agenda topic. Megan with the Governor's Office is here to share a little bit about 988 and implementation. Megan, I'm going to turn it over to you.
All righty. Hi there. Thank you for inviting me today. I'm going to try to share my screen if that's okay.
Excellent.
Let's see. Sorry about that. I got a notice I couldn't share. Okay, here we go. Can you give me a thumbs up if you can see that? Okay, and just to confirm, I think I have about 10 minutes. Is that about right today?
Yeah, I think it was 10 to 15 minutes. Yeah.
Okay. I just didn't want to overuse time. So, well, thank you for welcoming me here today. I'm going to go ahead and give you all a 988 update. Since I haven't met many of you, I wanted to just introduce myself and my position and let you have a chance to hear a little bit more about my role. So I am the 988 coordinator, and my position was developed out of the 988 legislation. So House Bill 1477 in 2021, and then it was extended here in this current session in House Bill 1134. So, oops, I am struggling with my tech here. So what I do really is I oversee the statewide implementation of 988 with several behavioral health partners. And I spend a lot of my time collaborating with Department of Health and Healthcare Authority on the items that they're accountable for in terms of the 988 work that we have laid out in legislation. I have worked with staff at Healthcare Authority and Department of Health to pull together a large cross-agency project structure. And so together with project managers and executive sponsors at those agencies, we are managing this work as a large cross-agency project. So I'm also on the CRIS as the Governor's Office representative, and I'm sure several of you are familiar with that if you don't attend yourselves. And CRIS is that statewide committee that was set up as a start in 1477 and continues to work today on the 988 work. And so I also, just for point of reference, work a lot with 911, specifically Adam Wasserman and as the 911 state coordinator, and I sit on their statewide advisory committee. Okay, so I just thought today, just to level set a little bit, I would just spend a minute or two talking about a couple of key things that happened both nationally and then statewide, just to reground everybody in 988. and how we started. And so we had federal legislation, just as a reminder, that passed in 2020. Then we had House Bill 1477 that passed in 2021. And we were the first state in the nation to pass comprehensive 988 legislation that also included additional infrastructure supports, which makes us unique among the nations. And then subsequently, we passed 988 related legislation this session as well, which I think we're here today to talk mostly about, which would be House Bill 1134 and 5120. We're coming up on the 1-year anniversary of the 988 line going live in July. So that's exciting, and we're looking forward to celebrating that. Okay, so what did the national legislation do? That established the 988 number as the number to call, similar to 911 if you're in behavioral health crisis. Dialing 988 now takes you to that previous 1-800-273-TALK line. And the National Suicide Prevention Lifeline still manages that network. And so when you call 988, your call starts there, and then it routes you by area code to our state and to one of the 3 contact center or NSPL's National Suicide Prevention Lifeline networks here locally in our state. So just to level set a little bit in terms of our statewide vision in crisis behavioral health and where we're trying to go, kind of dovetailing with SAMHSA best practice, is when someone's in behavioral health crisis, ideally we want someone for them to call that is, has a trauma-informed lens, has a behavioral health perspective, someone to call that's not necessarily 911. So what we're trying to do is have some place for someone in crisis or a loved one who's in crisis to call, someone to respond, whether that's responding on the phone, providing referrals, connecting people to services, finding appointments locally or regionally to support that person, or having a technical or a literal response, a team come to a person in crisis, some way to respond to them that's timely and meets their needs. And then ultimately, for the folks that need a place to go, whether they can't be stabilized on site or have in-home stabilization supports, where can we have a place for someone to go that's safe and offers the care that they need that's not the emergency room? So when we started with 1477 in 2021, the bill was comprehensive and included a lot of supports for our behavioral health crisis system, which we can be reminded about here in a minute. But a lot of the funding focus specific to the service fee was focused on the call side. Let's make sure we're set up on with an infrastructure to support calls. And so 1477 enabled that number. Again, this is 2021. Established the infrastructure for those 3 call centers, which currently are technically called NSPLs here in the state, but as we formally designate entities in the future to play this role, they will be called contact center hubs, but right now they're NSPLs. 1477 required next day appointments to be available and requires the development of a lot of new technology. And so when we have somebody call in, how's the call center platform work? How do we connect them from that platform to services so that it's interoperable with other data sets such as bed registries, appointments, et cetera. So there's a big lift in terms of technology that began with 1477. It also created that service fee to fund implementation, and that fee can be spent on things like paying for calls, staffing call centers, anything related to behavioral health crisis services in relation to a 988 call that was placed. And then that initial bill also established that Crisis Response Improvement Strategy Committee as well. And so when we look towards this session, 1134 continues to fund the capacity for someone to call, but it really started to zero in on this someone to respond zone. And so House Bill 1134 adjusts and modifies some of the requirements in 1477, but the spirit lives on. And it's, luckily with 1134, we got some additional infrastructure supports around mobile crisis response capacity and new funding. And so the regular or the existing rapid response teams that are currently funded through the BHASOs are continuing and expanding in capacity. And then the new community-based response teams are also going to be responsible of Healthcare Authority to implement. And so Healthcare Authority will be doing a lot of work in the near term here to establish standards for community-based response teams, and then also response metrics to improve timeliness were a piece of that bill. And so the idea is how do we expand our capacity to respond, and how do we respond in a more timely way to people who need our services? And it also establishes a little bit of a pay for performance approach. And so if you have a team that meets certain metrics over a certain period of time, and again, these standards need to be developed, then there's payment or reimbursement to support that success. 1134 also, excuse me, creates these regional training collaboratives that focus on, enhancing the knowledge base of our workforce. And so we have work ahead with our BHASOs, UW, Healthcare Authority, and my role and others too will be doing first an assessment of what regional trainings already exist and what fundamental principles are already a part of training curriculum, so we can pull from a bunch of different options and try to develop some training supports for other areas that may not have the same resources at some places to develop some solid trainings. And so as a part of that, we'll be doing assessment, we'll be making recommendations for training, and also developing materials. And then there's annual forums that are to begin as a part of this regional work. And so my understanding is we have, again, some planning work to do around there, but Healthcare Authority will be working with those key partners there to get some meetings kicked off. 1134 also built in some liability protections in terms of dispatching decisions and call transfers between 988 and 911. That was seen as something that had not been addressed in previous legislation and was important. There's also new educational and promotional requirements in terms of the 988 line itself, and how do we get more people to understand that the line exists and what it can be used for. 1134 enhances some training requirements. So that'll be, excuse me. And also best practices for reaching the most at risk. So 1477 has, the previous legislation has a lot of work that was required on behalf of HCA and partners around setting best practices. This elaborates or builds on that and requires some best practices for reaching some of our most vulnerable populations. From a payment perspective, 1134 allows Department of Health to support what's called co-location programs. And so these would be, some of our call center staff co-locating with 911 PSAPs in a region. And so they're exploring what these programs could look like and intend on piloting some here soon. And then 1134 also requires a percentage of the service fee or the tax to be spent on mobile crisis response teams that are affiliated with a tribe in Washington. So that's really exciting as well. So moving on to Senate Bill 5120. 5120 focuses in the place to go continuum of our vision here. And it establishes a new facility type. And this is the 23-hour crisis relief center. So a 23-hour crisis relief center provides a place to go that's an alternative to an emergency room when one is in behavioral health crisis. And importantly, it accepts walk-ins and drop-offs from first responders. It's open 24 hours, 7 days a week. It doesn't require medical clearance. And the goal is to accept as many walk-ins and as many of those that are brought there as possible, hopefully up to a 90% acceptance rate. There are criteria in there, and one of the next steps will be for DOH to create rules around these facilities, but there are situations, of course, where a transfer to a hospital and emergency room might be necessary when it's medically appropriate. These facilities need to have the ability to dispense medications. And DOH, as I mentioned, are going to be working on licensure and certification work, and that should be done around January of 2024. House Bill 5120 also we had a couple of terms that with similar definitions in the RCW. And so the crisis triage facilities have been retermed to crisis stabilization units so that we have consistency there. We're wanting services, of course, to be eligible for Medicaid, and there are requirements there around tracking and analyzing data from these facilities. So just in terms of, summarizing some of the funding that we have to support 988 related activities, and these activities will be funded by the tax, state, and federal funds. We are funding enhanced rapid mobile teams. We're funding the new community-based teams. We're continuing to fund the 988 call centers. There's new funding this year for supporting that technical work that's required. There's new funding to support a regional workforce training and the training collaboratives that we talked about. And then there's funding to support our 23-hour crisis facility designation from a licensure and certification perspective. There's no funding right now that's building 23-hour crisis facilities.
Megan?
Yes.
We have a question
Sure.
on the 23-hour facilities. The question is, why are they a 23-hour center when they operate around the clock?
Yes, so that's a good question. And the idea is that once you hit the 1 day or full, so it does, just for clarity, it does operate all day long, 7 days a week. But from a legal standpoint, if you hit a full day, you have different licensure requirements. So if somebody's staying there overnight, the thing that you have, things that you have to do in that facility are different. So it's 23-hour crisis so that it's clear that the person can stay there all day or up to 23 hours, but it's not an overnight facility.
Excellent. And does that mean if they hit the 23-hour mark, they can walk out in the street and walk back in?
Can they walk out on the street on their own? I know that there's a process to get folks to where they need to be next. I don't have the details on that today.
I guess the question is, can they restart their 23 hours if they exit and then re-enter after the 23 hours?
I think it's a good question. What's the time in between, discharge to when they can come back? I don't know that answer.
Tisha, looks like you have your hand raised.
Yeah, I was just going to jump in. Well, first of all, Megan, you're doing an awesome job with this overview. And also, often when I think about the crisis, these 23-hour, what's the term? Crisis facility. Usually, I often describe them as like an observation time. And typically, they probably wouldn't be standalone. So you might add it on to something else. Because that's exactly what you're describing, Justin. It's like, what happens after the 23 hours? And also all of these details that you are describing, I think is part of what we'll be figuring out in the next year is like we work with, as the Department of Health writes the WAC and kind of all of that good stuff kind of gets figured out.
Yeah, I know that's a pretty premature question, and I appreciate.
Well, yeah, I don't think it's premature. It's just, you live in this world, you work in this world, and it's very logical of like, hey, what about this?
Well, and they say in the bill too that it's a requirement of these facilities that if you have this 23-hour crisis designation, that you have as part of your work, that you have a warm handoff for your client to the next place that they're going. And that, of course, is concerning from a resources standpoint, right? Are all of those resources always going to be available? And so I think there's a lot to be worked out.
I appreciate that, Megan. Yeah, my thoughts go around sobering centers and the same issue. They've always wanted to do warm handoffs, but oftentimes individuals need 3 days, right? Up to 3 days. And so how does that work has always been a challenge for sobering centers.
In other states, and I'm sure plenty of you are aware of this, they have these 23-hour facilities as a step one on a campus of 3 types of facilities, right? Where you've got this, and then you've got your next steps with a couple of days, 72-hour evaluation, and then you have a next level of facility, which is a couple of weeks. And so some of the other statewide models have them as a part of a campus continuum, and that's been successful there. All right, so just to wrap us up here, in terms of 988 successes so far, we've had a lot of them, but just to pull out a couple, we have implemented or implemented a structure to support the work that we have to do together. So it's a success because, you know, each agency has their own business and their ways of working. And so I feel like it's a true success that we've been able to come together with genuine hearts and realizing we all want to move together to get to the same place. And so we've done a lot of work together, and you know, we've just started. So that's really exciting and it makes me happy. We've hired a lot of FTE, so it's a lot of work, a lot to do. Our call centers have been funded and are operating. We're hitting those 90% in-state answer rates that are required in 1477. The call center data shows actually higher than 90%. Our national data from Vibrant shows a little bit lower, and we're trying to work on them with that. And that's because sometimes when a call is transferred to our state, it doesn't actually ring in our state, but it's tracked from Vibrant as a call being referred. So we have no way to answer it. But so that's where the discrepancy is there. But still, we've met that metric in our minds, which feels really good. In Washington, another unique thing is our Native and Strong 988 line, which serves our tribal populations. That's not available nationally. It's only available in Washington. We have our final tech and ops plan that was approved, and that's under OCIO oversight now. And we're working with them to kick off our official working relationship for the new funds that are available for us to move forward. We released an RFI last month. We have received responses to that RFI, so we're evaluating them now. Our next day appointments went live in January with caveats. We have a lot of work to do there, depending on what sort of what all the kinds of payers in Washington, but BHASO contract amendments were in place to support that work in January. And Healthcare Authority has been working really closely with partners on our best system, crisis system practice, best practices guide. And so I'm sure many of you have been engaged with them on that too. I included these slides here, and I'll send a PDF of this deck. I'm not going to go through them today, but it's a DOH. So this is responsibilities, new work in 1134 for DOH. And I broke it out into big categories and talked a little bit on the bullet points on what each agency is required to do if you're interested to know a little bit more. And I made a slide as well for Healthcare Authority. So those might be useful resources for you if you want to know more. And I went ahead and tagged on this little update on House Bill 1004. I don't think it was asked for today, but this just generally allows 988 signage to be placed on bridges as they go up to advertise the hazards of jumping. And so just wanted to bring that up, that passed. And this authorizes cities and towns to erect those signs. And prior to contracting for any new bridge or bridge projects, it requires districts and corporations, et cetera, to consider that signage as part of a contract requirement. So I believe that's all I had for you today. I'm happy to take any other questions if you have it. I included my contact information here in case anyone wants to reach out.
All right. Looks like we have Commissioner Wes McCart. You were first.
Yeah, great presentation. Question I have from the national level. We've had some discussions at the national level that when a veteran calls 988 and identifies as a veteran, that they are automatically transferred to the veteran crisis line and served under that mechanism. And we were assured at that meeting by the VA that nobody ever gets dropped. So I would like to know if that's occurring in the state of Washington, and how are we making sure nobody's getting dropped?
So in terms of the veterans line, when you call 988, there's a dial pad option to opt in to veteran line support specifically. So if you call in and don't press for the veterans line, I can't remember. I think it's number 2. You will be routed to your 988 center in your state that way. If you select the dial pad option for veterans line, you will be connected to the veterans line. And in terms of how many of those calls are dropped, I don't know the answer today, but I could certainly connect with our partners and see if we even have a way of tracking that information.
All right, thank you.
All right, Jeff, you're up next.
Yeah, thank you, Megan, for your comments, and thank you for all your support of this. We have the opportunity to, as one of the 3 contact center hubs, to be chatting with you each month and sometimes in between. So your involvement in the governor's office support is really key in all this. So thank you again. I think just for the collective, I would make a comment or two on, one is that, this is all very visionary and very aspirational. And there are a lot of terrific elements to all of this, but it's also not at all uncomplicated. And I think, Megan, you did a nice job of explaining it in a way that was understandable, and also, especially this last couple of slides showing, there's a lot to this, and it's not going to happen quickly or overnight. There's a lot of inventing it as we go and developing it and figuring out how we're going to get from where we are now to where we're going to be in each region across the state. There's the 3, the 3 contact center hubs, one of which is King County alone, and we're within this region, the Frontier. And there's VOA of Western Washington, which is really, 32 remaining counties. So, there's the regional crisis lines already in each region. There's the 988 piece being layered on top. There's the, the mobile response teams. There's the next day appointments. You put all this together, I'm assuming and hoping folks can get that this is just a ton of moving parts. And when we have, the support of Healthcare Authority and DOH, Governor's Office, the contact hubs, and in some regions and with some providers, the contact hubs do not provide crisis response services or mobile crisis. So then they're having to choreograph that across multiple agencies. We're fortunate to have, the regional crisis line, the 988, lifeline contract, and mobile crisis and crisis response kind of all, within our organization. So, and that's not going to be uncomplicated unto itself, but I think there's some opportunities that we're striving to capitalize on. So I think part of it is just asking people for some patience around that, because it's going to take a while to figure it all out and kind of have it work as well as is envisioned. I'll also share, just as a point of reference, right now, about 85% of the calls that come into us on our regional crisis line, which is currently combined with our 988 line, about 85% of the call time is still people calling the 10-digit regional crisis line number. So it's still a minority that are calling 988, even though it's simpler to remember. It's something that takes a while for people to get acclimated towards. So a lot more publicizing of that, spearheaded by DOH, organizations and other partners, and hopefully any of you and your partners throughout our region, our community, I think is something we're striving toward. We still run into people who have first call for help volunteer crisis line. Some of our own staff have still had that on their answering machines, and that disappeared when their RCL came around, 4 years ago. So it takes a while for people to get used to it. But I do appreciate, Megan, all of your support with these efforts. So thank you.
Thank you, Jeff. Just one quick comment on that, what Jeff mentioned too, in terms of when I was talking about the vision of someone to call, someone to respond, and a place to go, and was referencing which bills support which legs of that vision. I definitely didn't mean to suggest that we've got them covered all in terms of, we're good to go in all of those areas. I just was trying to clarify you know, which pieces of the work belong where in that vision, because I think that always helps me to think about it that way. So, and Wes, I'll follow up with you via email if that's okay. I believe you were the one at the question about veterans and veteran calls being dropped.
Yeah, that'd be great. Thanks.
Okay, and a quick question for you. Do you know, are you hearing that veterans are being dropped from the point of pressing a dial pad to get to the veterans line? Or where are they having the problem?
So I guess what was confusing is when the 988 first started, is the VA was very adamant that nobody would get dropped as a veteran and not get served under the veterans crisis piece. And so just as county commissioners across the country, we are concerned. The last thing we want to do is have this crisis line available. And for some reason, folks that actually need the help, especially our veterans, are not getting to the right spot
Okay,
and not getting the help. So
all right.
it's
Thank
more
you.
of
I
a
appreciate.
concern, and I just want to make sure that we're not seeing that concern come to fruition.
Thank you. I appreciate that. I'll follow up by email.
Yeah. Sure, thanks.
Thank you, Megan, Commissioner McCart, and Jeff. And I want to just share too a little bit to echo what Jeff was saying. The regional crisis line, which is currently managed and operated by FPH and through a contract with the ASO in conjunction with our managed care organizations, is taking the majority of calls for our region as compared to 988. So for most of the crisis calls, we average about 4,000 a month. Again, that's rough average, with about 3,400 to 3,500 still coming through to the RCL versus the 988. And really 4 years ago, when we pushed hard to change from first call for help to RCL, we had some challenges with that transition. And now the community knows it so well, transitioning to the 988 is, again, where we were at 4 years ago when we were transitioned. So there's going to be a concerted push in the near future. Really, what we found is 988 is easier to remember. It's an access point for all individuals, and it is the future of where we're going in our region. Simply put, it is the best way for the community to connect, but you're getting the same people. You're still getting the hub here locally, and you're still getting connected to the services you need. That part won't change. And so I think we're very unique in our region to have that, to Jeff's point, all under one roof, have the same people responding, but also make it easier for individuals, not only to access one point of contact, but also to have access to the Native and Strong and to our veterans lines, which are also connected as part of that. So real big benefit. We are moving in the direction. We have a lot of plans to achieve that goal of transition. The number one focus that we have throughout that process is no one gets dropped. No one loses access. So please know that as we have conversations with the Healthcare Authority, Department of Health, Governor's Office, and with our provider, our entire focus is to ensure that all members get access immediately. And so there's gonna be some bumps and learning curves, but the goal is never to lose that part.
Yep, agreed. Thank you.
All right, any other questions or comments on that 988 section before we move on to Healthcare Authority? Seeing none. Megan, we very much appreciate your time and consideration today. Thank you for joining us.
Thank you. Happy to come back anytime.
Excellent. All right, I'm going to turn it over to our Healthcare Authority partners. I don't know where you want to start. We kind of put them in a list, but I'll turn it over to you for deciding who wants to go first with the three topics.
You bet. Thanks, Justin. We have Evan Klein here, and he's going to be, I think we're just going to stick with the order we have on the screen. We do have a PowerPoint that we are hoping on giving, and I'm assuming that Evan can just kind of screen share like Teresa did.
Yes.
I can stop sharing.
There you
And do
go.
we have, I'm sorry if you got, I was a few minutes late to stepping on the call. Did we say how long of a period of time we have?
Actually, that's somewhat flexible. So you
Okay.
guys have 15 minutes as well, but I can always shift my update to accommodate.
Wonderful, thank you.
Let me ask, oh, my Zoom's getting messed up here. Can folks see my screen, or is it?
Yes.
All right, perfect. Well, thanks, everyone. I'm Evan Klein. I'm the Special Assistant for Legislative and Policy Affairs here at the Healthcare Authority. I'm pinch hitting a little bit today. My colleague Sean O'Neill is supposed to be with us and is out sick this afternoon. But this is material that I'm pretty familiar with, and we have a good kind of cast from HCA here to support me as well. So Tisha and others, Teresa, if there's others who want to jump in with any of these notes, please feel free to do so, because they are the subject matter experts. And I don't want to use too much of your time, so I will move pretty quick through this material and really focus on a couple of the highlights. But I encourage others to stop me where there might be questions, because want to make sure that this is useful for you. So really just kind of the focus this session kind of was across the board in behavioral health, and you all are probably pretty familiar with many of the topics that were covered over the past couple of months. But really spanning the gamut from, behavioral health contracting, workforce issues. We knew behavioral health workforce issues were going to be a big topic of consideration for the legislature this session, and were for us at HCA as well. Treatment supports, enhancements to the crisis system. We'll talk a little bit about some of the work that came out of session, where we expect to spend significant time thinking about the crisis system over the next couple of months and couple of years, really. Children and youth, and then prevention as well. So I'll hit on a couple of the highlights as we go. In behavioral health and contracting, I think that one of the biggest bills we were engaged on this session was engrossed second substitute House Bill 1515, related to behavioral health managed care contracting. This was a Representative Macri bill, really thinking about the next potential Medicaid reprocurement, but directing the agency to kind of refocus some of our network access work around regional network access standards. So this bill passed. We have a lot of work to do as a result to kind of enhance our network access standards, think about that on a regional basis, some additional connectivity with BHASOs, and then some kind of forward-looking work thinking about how we engage behavioral health providers, counties, and others as part of any future reprocurement in the Medicaid space. And you all may be aware, but we had been talking about a potential reprocurement for our Medicaid managed care plans to take effect January 1 of 2025, and really tapped the brakes on that work at the start of the year, in part because of work we're doing as an agency on the public health emergency unwind and other major kind of projects, Apple Health expansion, and some other things we might talk about here in the behavioral health space as well. But so much as that gets picked back up, there are some provisions in 1515 that direct us to ensure there's some robust participation from the behavioral health provider community in a reprocurement effort. So some things for us to think about as that work kind of gets roadmapped over the next couple of years. The behavioral health workforce space really focused on certain professions. There has been some work over the past couple of years around behavioral health support specialists, and a bill passed, Senate Bill 5189 from Senator Trudeau this past session, standing up that profession. Our role is really focused on reimbursement and thinking about how a new bachelor's level profession might be able to help support access, particularly for Medicaid clients and other individuals that we serve through the behavioral health delivery system. And so, we had worked really closely with the senator on that bill and the University of Washington over the past year, and are happy to see that pass. And we'll be working on any state plan amendment changes or other changes necessary to ensure reimbursement for those providers that I believe kind of come online in 2025. And then some other work here, probably touching our sister agency at the Department of Health a little more closely than us at HCA, related to the behavioral health workforce, mental health counselor compact, and peer specialists. But all work that impacts the workforce that we're really heavily engaged with, invested in, and we have kind of the funding streams that often provide reimbursement for these providers. So bills we were tracking and engaged in, but have a little lesser role in implementation on. Some other, obvious, huge behavioral health bills that we were engaged on as an agency this session. 5536, the Blake bill, kind of reason for special session, had worked closely with the governor's office and both chambers throughout session on both the criminal provisions, but really closely on the, behavioral health supports and the investments included in that bill. So a lot to unpack there, and I think we are still in the process of digesting all of the requirements of that bill. So I would expect more to come in terms of updates throughout interim, but obviously a significant, volume of, over $40 million of investments for services included in that bill. And then 5440 around competency evaluations, requiring a court to determine if there's a genuine doubt as to the competency before ordering an evaluation. We were working really closely on that bill. And then 5634 on problem gambling, and 5502 related to substance use disorder treatment. Some other bills kind of in this space that we were engaged on during session. In terms of 988, there was a bill 1134 that moved through the House this year and passed, kind of enhancing some of the provisions related to 988. Obviously, we've been really heavily involved in the development of the technical and operational plan that was directed a couple of years ago, and worked with the CRIS committee, but saw 1134 kind of working on enhancements or endorsements for mobile rapid response crisis teams, directing us to work in collaboration with the BHASOs on recommendations for creating a crisis workforce. As I noted, I think there's a lot of work that we got from session related to the crisis system, thinking about both the workforce and also funding. And then some direction to the Department of Health on expansion of marketing of 988 efforts. And then there was also Bill 5120 from Senator Dingra around 23-hour crisis relief centers. That passed, which we were engaged on, creates a new behavioral health facility type, but also eliminates triage facilities as a facility type at the same time, but kind of thinking about staffing requirements and expansion of 23-hour facilities in Washington. And this, Tisha, others can correct me if I'm wrong, but I believe this is based on a model that some legislators brought back to the state from Arizona, some experience that was learned last interim in engagement with Arizona and some of their experience with 23-hour facilities. Related to children and youth, there were some recommendations picked up from the Children and Youth Behavioral Health work group, I believe, in 1168 related to prenatal substance exposure. These are predominantly requirements related to DCYF and developing treatment and family support services for children, but it does also require HCA to develop a report and recommendations to the legislature on increasing access to diagnosis, treatment services and supports as well. So some more work to be done within the agency there. And then related to children in crisis, creates a system to support children in crisis, and it requires that the governor maintain a children and youth multi-system care coordinator. It specifies some duties of the care coordinator and directs some additional reporting requirements as well. I think really directed at the governor's office, more broadly, kind of thinking about the interplay between our work at HCA and DCYF and some of our other sister agencies as well, but some more work to come. And then related to substance use disorder prevention and mental health promotion, a couple of bills here that I would say we were tracking pretty heavily this session, but loosely engaged directly on. So happy to provide some more information there, but we'll probably move on to budget items beyond some of the prevention bills that we had been engaged on. I might pause for a second and just see, you know, as we kind of breezed through a lot of legislation, but did want to take a moment to talk about items in the budget as well. So might just pause and see if there are any questions about some of those bills that we were engaged on this session and some of the work that's coming to the agency and to the state as a result of those. Hearing none, I know it's Friday afternoon, so I'm happy to keep going. And I will note, happy to put my information in the chat if you don't have it, and I'm sure others from HCA as well. If you do have follow-up questions that you want to take offline, send us an email. I'm happy to engage offline as well. So on the budget, you know, just the top line here is significant volume of appropriations in the behavioral health space. Obviously, there has been for years, and we saw a significant increase in those investments from the legislature. And that's something that, you know, we're excited about. You know, there's a lot of investment needed in the behavioral health delivery system, but it's also a lot of work for the agency. So, you know, as you hear me talk about some of this, there are a lot of unknowns still. We're unpacking a lot from this past session, and implementation is going to take us some time. You can see here 124 provisos of new and continued behavioral health investments. So a lot of exciting work, a lot of work to be done by the agency. In the 988 space, this is kind of a continuation of some of the bills that were passed this year, but there was funding for the 988 technical platform implementation, kind of the core backbone of the 988 system. So we were happy to see that in the final budget. And then some other funding here related to crisis response, crisis system enhancements, and crisis stabilization facilities. Some of that tied to the 23-hour facility bill, some of that tied to 1134, and then some other investments in the crisis delivery system as well. Generally in the behavioral health space, one of the biggest items, this wasn't actually in HCA's budget so much as directed at OFM and the legislature, but there's a new behavioral health joint legislative executive committee that was stood up this session, and that will be a committee co-chaired by the governor's office and legislators. HCA is a member participant, as well as some of our sister agencies, and I believe 6 legislators on that committee. And the purview is very broad, right? So this is an entity that's going to be stood up to, the way I would frame it, kind of take a landscape view and do an analysis of the current behavioral health delivery system, and then start to work on road mapping a strategy for the state. It's targeting, you know, a 5-year roadmap for state enhancements and changes to our behavioral health delivery system. So that's work that's going to take some time. We expect to be really heavily engaged in it as an agency, providing, you know, back-end data and analysis. But we'll certainly elevate some of these conversations with legislators and, you know, bringing the right agencies to the table. So we're hopeful that those will be fruitful conversations, and we expect some of that to start up later this year. And then you see here a number of other investments, behavioral health, personal care, SUD services and supports, some grants for BHASOs, and then related to CCBHCs, we did not receive the SAMHSA planning grant of $1 million to work towards becoming a pilot state, but the legislature did backfill that with state funds of $1 million to allow us to continue some of our work developing CCBHC payment methodology. So excited about being able to continue that this interim, and hopefully coming back to the legislature and to our federal partners with some ideas about how we can continue to keep that work rolling throughout Washington state beyond some of the pilot sites that are functioning today. True Blood, if there are any questions here, I'll put them to Tisha certainly, but you know, there was funding for True Blood phase 3, and you know, looking to expand programs and services to the Thurston Mason and Salish regions. And then some funding looking at increasing access to competency restoration and capacity for evaluations. We expect a lot of continued work in this space, and it's going to take us some time, to get these investments out the door. But obviously, this is funding that we had expected. It was in the governor's budget, and that we had worked really closely with the governor's office and the legislature on. Facility and bed investments. There were investments in civil conversion rate enhancements in Maple Lane, Stanwood, and then UW 90, 180-day inpatient and short-term beds as well. Again, we expected a lot of this. It was in the governor's budget, but we were happy to see that the legislature passed it to continue some of the work at these facilities, increasing capacity around the state. And children, youth, behavioral health. The one highlight here is, some of the additional funds around clip beds. We were happy to see that, and then just Project Echo and START trainings to see that get funded. There's a lot of continuation of existing work funded in this space, but certainly some significant investments, including in intensive outpatient and partial hospitalizations as well. And then just to note there that the Children, Youth, Behavioral Health Work Group's strategic planning funding was included, so that work will continue in that forum too. Grants and pilot programs. I would just note, for the agency, we have, I think, around 21 new grants and pilot programs across the agency. This is kind of highlighting some of the big ones in the behavioral health space. So a lot of work to do to stand up some of these new pilots and get money out to providers. But you can see here kind of a couple of the grants that we will be delivering beginning July 1. It's going to take us some time once we go through the allotment process within the agency and to get through renewal of contracts with existing providers that take us through the end of this calendar year. And then we get the funding in the door and start work on some of these new grants. So a lot of work to be done, but a lot of money going out to providers, which will be good. And so I would expect we'll have more information on a lot of these. If you have questions about timelines, when money might go out the door, where an RFP might be necessary, I would expect we'll have more answers as we get into July and early August. And do have details behind all of this about funding amounts as well, if folks have questions, just trying to be conscious of time. Opioid and abatement investments. Obviously, there was, the opioid settlement dollars were all appropriated in the budget. So here's just kind of a snapshot of some of where that funding went, as well as some additional state investments. Opioid prevention, support to tribes and urban Indian health programs, I think around $15 million going out to tribes. $5 million for naloxone, $10 million for MOUD in jails, money for Maddie's Place, for coordination with Department of Health on various campaigns related to harm reduction. So, again, significant investments in this space, more that's probably necessary for the state, but we were happy to see the legislature, ensure some of these appropriations. And then on rate increases, there were a number of rate increases. I think we would kind of frame a couple of the big behavioral health rate increases as one bucket. It really looked at, additional investments in managed care. So there's a 15% managed care rate increase. That's on top of the 7% managed care behavioral health provider rate increase last session. And then 22% fee-for-service rate increase. So fee-for-service providers were not included in the behavioral health provider rate increase from the legislature in 2022. And so they kind of made some steps to true that up a bit in this year's budget by kind of going above and beyond that 15% increase in managed care. There were also provider rate increases for certain codes in the physical health side of the budget, but really related to behavioral health services as well, kind of through section 211 of the budget, our general Medicaid section of the budget. And then we see here, some other rate increases as well for applied behavior analysis. That was a decision package that we had as an agency and was funded in the governor's budget. So happy to see that come through. And then behavioral health, residential room and board, and psychiatric per diem rates were funded in the conference budget as well. So a couple of items here looking ahead. Obviously, there's a lot of work to digest all of this and to get it implemented, get money out the door where necessary, build those rate increases and ensure they can get baked into rates for providers moving forward, et cetera. So a lot of work that I know our behavioral health team is already underway with, but a couple other pieces here just to draw you to like other work that's happening in the agency. And we'll be thinking about connectivity with our Medicaid transformation project and agency roadmap and strategy for kind of where we go with the behavioral health delivery system in next year and beyond, right? We're already starting to work on decision packages for the next legislative session, whether we want to or not. But with that, anyways, I know that's a breeze and kind of went through a ton of material. Happy to take any questions. Otherwise, happy to turn it back to my colleagues at HCA to take you to the next couple of topics.
Jeff, yeah.
Yeah, thank you. I mean, I don't have so much a question as just a comment. And one, thank you for your presentation and thank you for all that you covered. And as I and many colleagues have shared with our elected officials, a big thanks for all the attention and interest and investments being made in behavioral health. I think the one piece that I would accentuate it as being just ever so important is the rate increases, the increase in Medicaid rates, the increase in the non-Medicaid rates that support crisis and other services that Medicaid won't cover for our community behavioral health system. We are in, and I say this at each forum I have an opportunity because it's eminently true, and it's something that touches our world in community behavioral health every single day. Is the workforce shortage crisis is still upon us. It impacts every program, every service in different ways at different times, but we're continually strategizing as to how do we find ways to keep existing programs operational and afloat with continued high turnover rates, high vacancy rates, and that the 7% increase and the $100 million statewide in provider relief funds last year did help for sure. And this additional 15% is just, it is absolutely something that is the most important piece from my perspective. And I know many of my colleagues in this legislative session. Absent that, all the other investments in the world in new facilities, new programs, expansion of programs, it really becomes more problematic than it is helpful, because we simply don't have the resources to be able to compensate our staff to be able to recruit and retain and operate the programs we have. So that's probably understood by yourself and many others, most others on this call, but I just think it's so critical that it be fully understood and understood as we go forward, that as more programs are added, we're as important as that 15% is and is going to be when it's effective come next January. It's not going to be solve everything. So we're still going to have, not enough workers and a workforce shortage. Hopefully we'll be able to get us out of crisis mode in our organizations across the state. But it was significant headway made on that. So a big thank you to our legislators. Thank you.
And then, it looks like, Evan, thank you for responding to Commissioner McCart's question there. Any other questions or comments? All right, turn it back over to Tisha.
Evan, I just have to give a huge thank you to Evan. He does a great job on that presentation. He's so knowledgeable about all of the bills. So thank you, Evan. I believe Teresa is going to give a quick update next. And if not, I can
Tisha, this is Becky Carroll. I'm also on. If I
Wonderful.
need to go before Teresa, or I'm not sure what Teresa, I know I'm talking about the public health emergency unwind. So
Yeah, I think it's to Becky next.
Awesome.
I'm not on the schedule. I just popped on to provide support. Thanks.
oh
Don't listen to me. Listen to Becky.
oh no, not at all. Tisha, thanks so much. And I apologize for not getting my camera on. I'm having some connection issues today as I balance out my life. So my apologies for not doing that, but thank you everyone for having me. My name is Becky Carroll. I serve here at the Healthcare Authority as the Deputy Division Director for Medicaid Programs. And so really appreciate Evan's presentation there. It's always great to hear all of that great work framed up. Today, I'm gonna just touch briefly on the public health emergency unwind. And I would just say happy to come back next month as well. I think we'll have more data to share and some additional details then. And so happy to come back with a presentation on those pieces. So I'll offer that. But I think you're all aware the public health emergency for COVID has ended and that the Medicaid program is back to quote business as usual as of April. And so in April, we sent out our first set of redetermination letters for individuals who needed to renew in the month of May. And so all noting, right, that we're in June, those terminations have been taking place for those who are either no longer eligible for Medicaid or have moved on and have, we hope, employee-sponsored insurance or have found coverage off the quality, the QHP from the Health Benefit Exchange. But again, not a lot of numbers that we're ready to disclose publicly just yet. We are still working on that. There's a little bit of a lag on our data. But we are back in motion in Medicaid as far as those monthly renewal cycles for individuals who are eligible for Medicaid. You probably are all aware they do that once a year for the most part. So we continue with outreach, and I think that's really the message I want to push forward here today. We are contacting individuals first 2 months prior to their renewal. We're sending a postcard, just making sure that we've got all the right information for them. Then they do receive their normal renewal letter. And then we start a text message campaign for anybody who hasn't responded to their redetermination letter or renewal letter. They get a text message from the agency asking them to respond. If we still haven't heard from them a week and a half later or so, they'll get a robocall that hopefully will prompt them to reach out and to complete their renewal. I'd say just really at the same time, our managed care organizations have done a really good job of doing outreach to members. So they are not only just hearing from the state of Washington, they're hearing from their Medicaid managed care plan as well. And hopefully from providers they're interacting with. But we are doing a lot of outreach for individuals, as you can kind of tell. They're getting quite a few touch points prior to their renewal date. Once we've gotten close, if we haven't heard from them, they get a pre-termination letter. Hopefully that prompts a response. If it doesn't, and an individual does let their coverage lapse, they, for the most part, can come back onto Medicaid if they still qualify and have a retroactive period up to 90 days. So we can bring them back into Medicaid if they qualify and retroactive their coverage for the most part 90 days back. So again, lots of state outreach, Medicaid managed care outreach, our provider network and community-based organizations, community health workers. We've been working really hard to bring them into our ambassador program, which provides sort of a communication toolkit for individuals who are working specifically with Medicaid clients out in the field. And so all of those tools and resources are available on our website, and I'll pop that into the chat here shortly, but just wanted to kind of give you an overview of those things. And I'll just pause if there are any questions, or if anyone from the Healthcare Authority, any of my colleagues have anything more they would add there.
Becky, I'm
All
not seeing
right.
the chat.
Okay.
I do have one question for you. You say that you do
Sure.
a text message and phone call. How up to
Yeah.
date are a lot of those contact information?
You know, that's a really great question. We did do that. Postcard is really meant to have people update their information with the Healthcare Authority. Our managed care organizations have also done sort of a renewal period inquiries with their recipients to ensure that we've got all the right information. It seems anecdotally, and like I said, happy to come back next month with some additional details around the data, that we do have the right numbers for people. Those text messages, in the rough numbers that I'm seeing, again, the data needs to be scrubbed. It seems like there was a really great response, and that our text messages were hitting the right people for the most part. So pretty good, actually, surprisingly so. But yes, it seems like those text messages and robocalls are reaching the right people for the vast majority of folks. And I want to say pretty, I think, significant numbers. But again, I'll have actual data next month that we can certainly come back to share.
Excellent. Thank you.
Yeah, absolutely. Any other questions or thoughts? I think Evan already covered the second bullet point that I was asked to speak to, which is the managed care organization reprocurement. I think he noted that we are intending to reprocure. We had intentionally released kind of this January 2025 date. We do have that on hold as we really just ensure that the public health emergency unwind and so many of the initiatives that Evan covered and more are successful. And I think we'll be happy to come back and talk more about that once we have a firm date for reprocurement. So always appreciate the time to address all of you. And if there's any questions or if you have any follow-up, I'll make sure that I put my email in the chat as well.
Excellent. Thank you, Becky.
Thank you.
Back to you, Tisha, for the last agenda topic.
Yeah. I believe at the last or a previous SCRILS meeting, there was some questions about the intensive behavioral health treatment facility that is being built and added on to a current assisted living facility in the Chewelah, in Chewelah. I wasn't at that particular meeting, but I certainly can give an update on kind of what my activities and kind of the healthcare authorities and commerce, and also I believe some folks from commerce are here, and just kind of what we're doing to listen to and address the concerns that we have heard so far from the community. I'm also, before I start, if people had any particular questions, I'm happy to take those first, or I can just kind of dive in. I'm going to do the dive in approach, and please feel free to ask any questions as I go along. So back in sometime this winter, I guess I just wanted to start the presentation by giving a thank you to Senator Short and also Representative Maycomer, who this winter brought a group of local officials and also state government officials together in a conversation to be able to say, hey, we're hearing concerns from the community about this facility. This is a new type of facility. Kind of can we all get together and kind of figure out what's happening and kind of learn more about this. So that really, and actually the governor's office was there at that point also. And actually today on the call, we also have representatives from Commerce that have kind of been part of this whole process also. They might want to also jump in and give some perspectives. So since Senator Short really brought us together. One of the things that we did is we actually went in the beginning of April. There was a small group of us that went over to Chewelah and met with the mayor and some, who else was there from the mayor? The mayor and some other leaders from the community, and actually took us on this, had a wonderful day together where they took us and drove us around the town and drove past the facility, and also had us a stop at the school and met with the principal there. Also went over to the hospital, was able to speak to the director of the hospital and learn about things from their perspective. We were also able to speak to the outpatient provider in the town and kind of what their perspective had been, and just try to answer any questions the best that we can. Since then, really what we've been working on as different state agencies that are just involved in the process of bringing forward kind of new types of behavioral health facilities is really getting a really strong understanding so we can answer the community's questions about what are all the different state agencies' roles. So what is the role of the Department of Health? What is the role of Commerce? What is the role of the Healthcare Authority? What is the role of the provider? And kind of how did things kind of roll out how they did here. Another thing that we've recently done, and I believe I saw that David Nielsen was on the call earlier, and I'm not sure if he still is or not, is he was kind enough to host myself and a couple of others of my colleagues from the Healthcare Authority when we went up to Colville to visit, his community behavioral health agency to get a better understanding of the outpatient services in Northwest Washington and also the crisis services. And in a couple of weeks here in July, I believe there's a contingency of different state agency officials that are actually meeting with Senator Short in the Chewelah region to be able to come back together as a group to, again, kind of continue this conversation, to learn more, lean in, and kind of assess where are there areas that we still need to learn more, to hear from the community, and then brainstorm any potential ideas for solutions or moving forward. I don't know if my partners from Commerce would jump in and give any perspective, or anyone else on the call.
I think your summary was great, Tisha. Thanks.
Yeah, Tisha, I think it was great, and I think it just draws the importance of clearly communicating, because there is such a agency, local governments, regional perspectives, and so just making sure. And I believe we've learned a lot here in how to increase our communications and working together with community, with each other in the delivery of these very critical services. So thank you.
Is everyone familiar with Mark?
Mark Barkley, Assistant Director at the Department of Commerce. We work very closely with local governments across the spectrum of water, sewer, storm, infrastructure systems, community facilities, growth management, et cetera. So happy to be here and appreciate listening in on this very important topic.
Excellent. Thank you, Mark. I don't see any other comments or feedback there. I know, Tisha, that our members from Northeast Washington.
I'm so sorry. I said, thank you.
Yes, from Stevens County and Northeast Washington. They have been working with you. So this was really an update for the group to ensure that there was a follow-up to that topic. We made it one of our quarterly updates, and we'll touch back at our next quarterly meeting just to see the outcome of that. If there's no other comments, we appreciate the feedback and the support that Commerce and Healthcare Authority and the state is given to respond to the questions and concerns at the facility up in Chewelah. I think that concludes the topics for Healthcare Authority. Tisha, you and your team, I very much appreciate your time on a Friday evening to joining us. So thank you so much.
Absolutely. You know, this really, I mean, we have our role at the state and you guys have your role in the local level, and it's really, we can't do a good job if we don't hear your perspective. So I'm always happy to come to any type of local event. I think it makes it so much easier for us to do our job. So thank you for the partnership. And, you know, I have to say, earlier, Evan said, hey, we got a question about True Blood. You should ask Tisha. In my head, I was thinking, well, what I often do when I have a question about True Blood is I ask Jan at Frontier. So she's also a pretty good subject matter expert.
I asked Jan too. So I think Jan's just the go-to.
Well, this is Jeff. I'm her boss and I ask her too. So we're all there.
So it's very consistent. It's very consistent. Yeah. Thank you.
Yeah, thank you, Healthcare Authority. All right, being respectful of time here, I'm going to turn it over to Megan. In the last meeting, we had discussed different investments that were going on with Commerce for our region. And so we'd asked Department of Commerce to just give an update on what kind of impacts will be our region be looking at if there's any new investments. So turn it over to you.
Hey, thanks for having us. I know some of my Commerce colleagues have had to sign off. We did have a 3 to 3:30 time held, so I'll try to move as quick as possible to get us out by 4, as many folks have been putting out their other obligations to be here at my request. So I just appreciate the time, and I'm excited that we have folks here on the call. As you already heard from Mark. Thanks, Mark, for introducing yourself. I'm Megan LaPalme, Community Programs Manager at Commerce, and that means I get to support both our behavioral health facilities and our early learning facilities teams. And I think that Leslie is here. Leslie, do you want to do a quick intro?
Hi, folks. My name is Leslie Wolf. I am, as of February 1st, the Behavioral Health Facilities Supervisor over the Department of Commerce. I'm very happy to join you today. Thank you for hosting us.
Thank you for joining. And I think, and Addie Craig was here. She had to take off. She has a little to pick up. So I'll jump in and just share some slides. I'm wondering, oh, I need permission though first. Thank you. I'm wondering if it would be helpful to talk about the behavioral health facilities grant program as a whole, or if really you're looking at new opportunities for funding and new investments. You want to give me a little guidance there?
Yeah, I think in the past, Department of Commerce has given some background on the actual behavioral health program. So if that's easier to jump in and give an update on what investments, it might be helpful, and it might lead to other questions. So that's where I'd start. And if there's any additional requests, then of course people can speak up.
Certainly. Okay. Looks like you're probably seeing the wrong screen. All right. Does that look better? Can you see my slides there?
Yep.
Okay. All right. So let me just zoom through a couple of things here. Obviously our intro slide, and here's just a little bit about Commerce. I know Mark shared more about what our division works on, but as a whole, Commerce's goal is to strengthen communities. And for behavioral health facilities, we really think about that as bringing folks treatment closer to home, right? That's the whole goal, is to get treatment opportunities for folks close to their networks and where they have social supports and family supports. So that's our goal. And here are just some basics about the program, but like you said, you've got most of this, so I'm happy to share these slides if anyone wants to look at them later. So basic program information, we do have current funding opportunities available. So if folks in the region are looking for an opportunity to build a crisis stabilization unit or expand a facility that they have, or open a youth residential crisis stabilization program. We just call that RCSP to keep it short. We do have grant funding available. So you can see on the right side here that Pre-applications are due June 15th, and that's a short turnaround. But if you're in, or if you know someone in the region that's interested, please let them know. There is time to get that filled out. And then there is another 2 weeks after that deadline to get the general application submitted. So, so folks, there is funding available. And in the future, this is what we see coming. Evan gave a great overview of the behavioral health funding and policy changes from the legislature. This is funding that was directed to commerce in the capital budget. So in the next biennium, these are things we hope, or we know we will be seeing. We have regional needs funding pot coming up, and there are priority facility types in that with 9180, long-term commitment beds, state hospital diversion, which we're kind of figuring out what kinds of facilities fit into that. It kind of seems broad, so it may be all kinds. Secure withdrawal management and substance use disorder treatment. So that's part of the regional needs. We do have more funding opening up for IBHTF facilities, children and minor youth facilities, and then this new bucket of closure prevention funds. So we're anticipating these will be opening in the fall of 2023, though y'all know that things happen. That's our goal, and we're really intending to have that open maybe September, October region. And if you're interested to find out when those do come open, you can sign up for updates on our website. And maybe Leslie, would you want to put the web link in the chat so folks can sign up there, or if you know someone else in the region who's interested in that. And I think you all know we have lots of partnerships across the state agency and regional networks. So this is just a quick list of all the folks we work with, because we're not the behavioral health experts. Our friends at Healthcare Authority, Department of Health, and DSHS, and our regional groups are all of those experts. So we all work together to make this come to life. And like I said, there's the email notification thing, but we got that in the chat. We have some more information here about how projects are selected and located, but I think that might be something you already know. So I'll keep moving. These were projects that were funded in 21-23 in the Spokane BHASO region. So in 21-23, it looks like everything that we funded for commerce facilities was in the Spokane County. You can see the grantee names here and the funding category, which you probably already know. A direct appropriation is one that's decided by the legislature, and we administer that contract with the grantee. So you can also see the anticipated bed numbers here. This you see NA here. All of our grants need to expand capacity for behavioral health services, whether that's new beds, whether it's new recliners in those kind of 23-hour facilities, or whether that's new outpatient capacity. So here, when you see NA, means that this is an outpatient facility because they don't have beds. Obviously, people aren't staying there. It's outpatient. But overall, in the 21-23 biennium, increasing the capacity in Spokane County and in the region as a whole by 48 beds and 2 outpatient facilities. And I will, again, share these slides so you can take a deeper look at that later as well. And then this is looking back a little bit further. So previous to or prior to 21-23, these were the investments that have been made in the region. So you can see there's a little more diversity, fairly, in the counties who are getting these facilities. So Stevens and Ferry are also represented here, along with Spokane. But we see that a lot. You know, the big regional hubs do have typically more folks are accessing our funding because the need is great. So prior to 21-23, we had 350 beds created with the Behavioral Health Facilities Program and 5 outpatient facilities. You can also see the anticipated completion dates here. Not all of these are completed yet. Because of the pandemic, folks have really had to slow down their projects, but it's really starting to pick up again. So we anticipate seeing a lot more coming online relatively quickly. In the construction world, relatively quickly, we're thinking in the next couple of years. And Justin, you had asked for kind of a spotlight on children and minor youth projects. And this is what we have. These are the projects that we have funded, the grant applications that have made it through like the whole program for BHS since 2017, 2019 through 21, 23. This is where we're at. You can see these three are outpatient facilities. One for Excelsior, Healing Lodge of the Seven Nations, and Providence Sacred Heart Medical Center. And then prior to that, Excelsior had a couple more projects that were that we don't have all the details on here about what type of facility they are, but they do serve children and minor youth. So looking at coming online dates, this is what they had proposed in their applications. And I know Excelsior is working really hard to get their projects online, but we don't have any new data about when they will be completed if they're not yet. So that's my very quick look at our projects in the region with Department of Commerce, and happy to answer any questions.
So Megan, you had indicated that there is 2 facility types that are currently open for youth that you are taking applications for. The stabilization and a youth crisis facility, is that correct?
Yeah, let me pull that back up here. So the crisis stabilization units those can be child or adult. And you know, folks apply for what they are able to complete or able to operate, and then the youth residential crisis stabilization program, so more of the residential type facility.
And are you only selecting one award, or is that multiple awards?
Oh, this should be multiple awards. And Leslie, if you are still able, do you know what is the cap for the funding for each award? Oh, she might have had to sign off.
No, I'm here. Sorry, I
Oh,
was
there you
just
are.
trying to find my mute. So let me pull
No,
up
you're
my other
good.
screen. I'm working one screen today. Sorry.
Thank
So
you.
for the crisis stabilization units for adult or child, the maximum award amount is $5,820,000, and it is also $5,820,000 for the RCSP.
Perfect. Thank you so much.
And I know it's probably a little premature. Have you seen interest in our region, or is it just kind of wait and see still till the application's closed?
Good
I'm happy to
question.
jump in and answer that. Right now, we'll know a lot more about that by the end of next week. We're still analyzing the pre-applications, so we can't really speak to that yet. Pre-applications will be due at 5 p.m. on June 15th. And we kind of anticipate we're going to see most of those coming in next week, maybe on June 15th. But we are requiring that folks have their pre-application approved before they can move to the general application. So we'll have a better feel for that next week.
Thanks, Leslie. Any other questions from those on the call?
If I could, I'd just like to offer that we'll also be at AWC in Spokane. We'll have a table, and we'll be also presenting in a couple of different areas, not just on behavioral health, but on broadband, some other things. So if you can help us spread the word, we'll have a table there and be open to questions. And another opportunity later in October at this conference we call Infrastructure Assistance Coordinating Council, or IACC, in Wenatchee in October. So plenty of ways to connect with us and work on kind of projects and funding guidelines and things like that. So it's a great forum, and we appreciate you helping us get the word out and let us know if there's anything else we can do for you.
Appreciate that, Mark. Thank you. All right. I don't see any other questions, Megan. I very much appreciate you and your teams, Mark and Leslie, staying on the call with us. I know this is late in the day for you also. I very much appreciate your time and consideration and sharing today.
Well, thank you so much. And if I can drop the slides in the chat, would that work for you, or should I email them?
Either or will work.
Okay, cool. Thanks so much.
Yeah. We're at the end of our hour, so we try to make it available for any community or public comments. Going once for any public or community comments.
So Justin, I missed the most recent conversations with the crisis system about what's going on with ambulance rates. But since Teresa Claycamp is here, and I always go to her when I have these issues, I just wanted to really quickly talk about our DCRs. And I understand this is a statewide issue, but our DCRs are increasingly unable to access transports when we do ITAs. We used to work with AMR out of Spokane. They stopped coming. Deer Park for a long time was their provider. They refused to come because of loss of funding. We worked with Ponderay Ambulance for a long time. They won't come. And we've recently met with Stevens County 911 Ambulance, and they tell us that they go in the hole for every ITA run, so they refuse to do transports. We're increasingly at the point where our DCRs are stuck in emergency departments where they have found a bed but can't get a transport. I've heard that the ambulance rate is going up July 1st. And so just, two questions. One, is that a fact? If so, what is the rate going up to? And is there anything else that is being done? Because our DCRs and our people who need involuntary beds are really struggling. Help me, Teresa.
Yeah. Hi, Teresa Claycamp. I don't know if that's in the budget or not. But we can take that as a takeaway and follow up. And I don't know if anybody else on the line knows that offhand.
Teresa, it's Carrie. We
yeah.
do not remember, David. I'm hesitant to say anything because I can't remember exactly, but a few of us remember being in a meeting where there was a talk about an increased rate for ambulance services. I just don't know exactly what that extends to. So let us go back. I think exactly what Teresa was going to say. We'll go back and talk with our team and make sure that we can get the direct right answer. But we do hear you. Ambulance is it's going to be we need to pay attention. So we'll come back and let you know what ended up in the budget and what kind of increased rate there may be, and kind of go from there if that's helpful.
Thank you, Carrie. Any other last comments from the community stakeholders or public? Going once, going twice, and third time's a charm. I would like to express my appreciation for everyone on a Friday evening hanging in tight with us after the hour. Go and have a wonderful weekend and enjoy some time off, hopefully in the sun. Everyone have a wonderful evening. Thank you.
Thank you.
Thanks, Justin.